So for the last speaker of this session, I'd like to introduce you to Dr. Ed Breitschwerdt, and he is a professor of medicine and infectious disease at North Carolina State University College of Veterinary Medicine. He's been studying the genus of Bartonella for many, many years. I think he's probably the world's greatest expert in this field. And he's going to talk about something that's very important, which is the Bartonella bacteremia and neuropsychiatric illnesses.
Hello, everyone. I first want to thank the organizers for the invitation to be able to present some of our research today. Second, it's just clearly an honor to be able to follow John and Brian and their pioneering work that's been going on for decades and continues to this day. In the context of relevant financial or non-financial relationships, I do hold a patent with Dr. Sushama Santaki of North Carolina State University for using an insect-based biochemical composition growth media to enhance the growth of microorganisms, particularly Bartonella. I am a co-founder, shareholder, and chief scientific officer for Galaxy Diagnostics, a company that provides advanced diagnostic services. I do not intend to reference any of the off-label or non-FDA approved usage in this presentation, and the work that I'll present was performed at the College of Veterinary Medicine at North Carolina State University in association with our physician collaborators. Before we move on to the subject at hand, I just want to emphasize the fact that was well illustrated in John's lecture, that Bartonella not only affects the nervous system, but literally affects every system in the body. And increasingly, the importance of this organism in the context of cutaneous manifestations is coming to bear, both, I think, in animals and in humans. But obviously, you see the muscular system, the skeletal system in the context of osteomyelitis or polyarthritis. I list the thyroid here, but I think we need to consider every endocrine organ in the body. And then uniquely for Bartonella, this vector-borne organism can localize to heart valves. It can cause endocarditis, myocarditis, hemolytic anemia, thrombocytopenia, vasculitis, and thromboembolism, with the latter four being less well studied at this point in time. But again, we're on Dr. Alcott's slides as autoimmune manifestations of systemic infectious illnesses. We became particularly interested and published this review article, again, with Dr. Santaki and Dr. Sarah Hawkins, a pediatric neurologist, trying to understand what might have been going on in veterinarians that we had begun to test, and I'll come back to that in just a minute, for evidence of Bartonella infection. I would emphasize that in this review, the cases are primarily based on the recognition of historical cat scratch disease or an acute presentation of cat scratch disease in that particular patient. But what it emphasizes is not only neuropsychiatric manifestations, but everything from encephalitis, transverse myelitis, to Guillain-Barré syndrome.
Pardon me, Dr. Breitschwerdt?
Yes.
Would you be able to change your view of your screen?
Oh, I'm sorry. I sure can. You can see it now?
Perfect. Thank you.
My apologies. So in the context of Bartonella cell tropism as neurologic disease, Bartonella can infect endothelial cells. One of the PhD students in my laboratory looked at parasites. Many laboratories have looked at various macrophages, including dendritic cells. And we've also, which has been mentioned by both our previous speakers, documented intracellular infection lasting 6 weeks in culture in microglial cells. So Bartonella can likely gain access to the nervous system by penetrating the blood-brain barrier through endothelial cells or parasites, migrating to the nervous system through macrophages, essentially the Trojan horse story, It can be maintained within the brain by microglial cells, which again is a focus of our research currently, and can be isolated, at least from dogs and humans, from cerebrospinal fluid. The organism, similar to what Dr. Embers has emphasized in regard to Borrelia burgdorferi, is very good at hiding in the body and using immune evasive tactics to do this. One thing that makes Bartonella somewhat unique that was actually investigated over a decade ago and hasn't been much since, which I think would be very helpful, is that the lipopolysaccharide of Bartonella quintana is anti-inflammatory. So anti-inflammatory, in fact, that when they put this into a rodent model of arthritis, it was equally effective as using prednisone in therapeutic dosages. And then most of the information on antigenic variation comes from either Bartonella quintana, referred to as VOMS or outer membrane proteins, or BAD-A, work done by Volker Kempf in Germany primarily, but other laboratories, where Bartonella henselae and Bartonella quintana can modify its surface proteins. Essentially, it would be like you can see me today, but you might not be able to see me tomorrow, which again has major implications in regard to serodiagnosis. And then a unique aspect of Bartonella is that it has a unique type 4 secretion system that injects effector proteins, or BIPs, directly, Bartonella effector proteins, into cells. You can see BIP-A inhibits apoptosis, which facilitates the vascular tumor formation. BIP-C facilitates invasome-mediated cell entry. And BIP-D is responsible for the immune downregulation, at least through IL-10 that I had mentioned. So in the context of neuropsychiatric illness, I want to start with 3 patients that we've published. And the first is an 18-year-old woman with a 4-year history of progressive peripheral visual loss, sensory neuropathy, and hallucinations. Again, similar to the second slide that I showed you, she had other problems involving joint pain, back pain, dizziness, those type things, had been evaluated by a neurologist, psychiatrist, and neuro-ophthalmologist. And for each of these patients, for the physicians, the question would be the same. And again, I'm a veterinary internist, so I get to ask this question myself every day. You know, would you test this patient for Bartonellosis? And if you did, what test would you request? The second publication in medical microbiology and immunology is a 14-year-old girl with a 5-year history of intermittent fever, ocular pain, balance problems, headaches, irritability, blurred vision, memory loss, insomnia, tremors. And again, like patient number 1, also had a substantial number of systemic manifestations with fatigue and joint pain and muscle weakness. Also, this patient likely had autonomic output abnormalities, which again, Dr. Alcott emphasized in his talk, and we'll mention a couple times in the context of my lecture on Bartonellosis. And then our final patient, published in the Journal of Central Nervous System Disease, was an 18-year-old boy with an 18-month history of progressive neuropsychiatric symptoms. His diagnoses included major depression, psychoses, and schizophrenia. He had been evaluated by 4 psychiatrists, hospitalized for 2 months in a specialty hospital for detailed medical and neuropsychiatric testing. Once Bartonella was diagnosed, and we'll come back to this boy in a subsequent set of slides with more detail for you, his neuropsychiatric symptoms resolved. And again, I thoroughly agree with Dr. Fallon, is what we need are controlled studies now in patients in which we have excellent documentation for borreliosis or Bartonellosis or both infections. But importantly, and what I want to emphasize is patient number 1 was infected with Bartonella cholerae. Patient number 2, who clearly was not an indigent, homeless individual who should have an exposure history for Bartonella quintana, was infected with that organism and co-infected with Bartonella vinsonii subspecies vinsonii, an isolate that we've never had in our laboratory and a DNA sequence that we've never amplified from any other animal or human in the history of all the work we've done with Bartonella. And patient number 3 was infected with Bartonella henselae. And again, all of these are based on PCR amplification, DNA sequencing, and we have multiple negative controls that are run with every set of patient samples. And for each of these patients, all obviously tested at different points in times, controls remain negative. In the context of the young lady that I presented that was infected with Bartonella cholerae, this is really important for the clinicians in as much as you'll see, we were actually doing only Bartonella henselae, Bartonella winsonii, and I didn't put it on the slide, but Bartonella quintana serology at that point in time. And this patient, when she first entered our IRB study, Ricardo actually got a positive PCR result, but we were unable to demonstrate that in enrichment culture. And this titer was done retrospectively. So what ended up happening is she was essentially lost to follow-up for almost a year, at which time her mother recontacted us and said her symptoms were actually progressing and getting worse, and we agreed to retest her. By that point, we had developed a Bartonella cholerae IFA antibody test, primarily to test cats and dogs. And you can see that she had antibodies at the time we initially tested her. She had antibodies subsequently, and she was consistently negative for henselae and quintana. So this specificity we certainly see in acute infections, and both in dogs and humans, and sometimes we actually see it in chronic infections. But you can see here with enrichment culture, we were able to document and sequence Bartonella cholerae. She was treated at Duke University Medical Center by Dr. Chris Woods and had near total resolution of all her symptoms. So the important part of the Bartonella story that many of you are familiar with is that in 1990 and before the AIDS epidemic, we did not know that this bacteria existed or ever infected an animal or human in North America. Then what happened over the next couple of decades, and continues to happen to this day because we've added another 4 in Bartonella species or Candidata species in the last 6 months, is that we keep finding more and more Bartonellas in more and more reservoirs, and regrettably, more and more vectors that are either thought to be vector competent or are proven to be vector competent. And then the other problem is other modes of transmission that are not associated with vectors. So I debated whether to include this study, but I include it mostly to emphasize the fact that why is a veterinary internist and infectious disease researcher who actually worked on Rickettsia and Ehrlichia and Babesia prior to being able to spell Bartonella, giving a lecture on Bartonella and neuropsychiatric disease in humans. And it actually came from testing veterinary workers, predominantly veterinarians, but some veterinary technicians and other people that work in the veterinary hospital environment. And this is a study with Paul Antus and Chris Woods at Duke University. We did all the testing, they did all the sample collection and all the analyses. And the important message here that I want to emphasize is that these were essentially veterinarians that were healthy enough to attend a national or international continuing education meeting that occurs every year in Orlando, Florida. And you can see 28% of these individuals had Bartonella DNA in their blood. And as might be expected for veterinary workers that are at a mostly companion animal veterinary continuing education meeting, they are infected with the Bartonellas that we find in cats and dogs. Volans is in squirrels and hasn't been characterized completely as to what the actual reservoir is. And as we've reported both in dogs and humans, co-infection rates can go from 6% to 18%, depending on how much testing you do. Dr. Woods provided 32 non-veterinary medical professionals from Duke, essentially medical students or other people working at Duke Medical Center, all of whom were negative. But the only thing I'm going to mention here that we'll come back to when we get to the patients that we've looked at in more recent years with neuropsychiatric illness is the fact that headache and irritability, and then you'll see the muscle pain and joint pain. And the other thing, and again, regrettably, why these people were treated with antibiotics was not part of the IRB approved questionnaire that was utilized, but statistically, those that had Bartonella DNA in their blood had been treated with antibiotics. Age and gender was not a factor, but interestingly, travel to Asia was a factor, and that's something we still don't understand, but I think complicated a study that we'll get to at the end of this lecture. This is a slide that was recently generated by the newest PhD student in our lab, and I use it just to emphasize that we're now transferring or transitioning to neuropsychiatric dysfunction, of which there's certainly a very broad spectrum. And as Brian pointed out, our infectious diseases are likely a cause, but they are not the cause in many instances. So coming back to our 14-year-old boy, infected only with Bartonella henselae, as well as we could tell, who did not have antibodies to Bartonella henselae. He had a sudden onset of psychotic behavior, his hallucinations, delusions, and suicidal tendencies, and failed 18 months of psychiatric medications, which you'll see on the next slide, as well as immunosuppression, rituximab for autoimmune encephalitis. So if you can see the timeline at the bottom of this figure, and then the initial place to start, obviously, was his initial hospitalizations, being seen by a pediatrician, EEGs and MRIs done to rule out various forms of brain disease that could be causing his behavioral abnormality. Then, as occurs with many of these patients, a cardiologist becomes involved primarily because of POTS type abnormalities that the boy was experiencing. A neurologist, an infectious disease physician, ultimately this long duration of hospitalization in a specialty hospital outside of the state in which the boy resided. And what ended up happening is ultimately the boy was seen by an integrative physician who is a co-author on this particular manuscript. And the nurse recognized these lesions, which physicians have associated with Bartonella infection for well over a decade. And obviously that was controversial, remains controversial. Initially, I found it very hard to believe that these lesions might be somewhat prototypical for Bartonella, but I do think they can occur in patients with Bartonella. So when I reviewed these slides this morning and looked at this particular slide again with the same timeline, and looking at the neuropsychiatric drugs that were initially used, and then the anti-inflammatory drugs for autoimmune encephalitis, and then the large number and combination of drugs, particularly antimicrobials, I was struck by the fact that for a patient, this would be a bit of a pharmacological nightmare. And again, one, I've always said to my internal medicine residents, the kindest form of therapy is an accurate diagnosis, and we need better diagnostic tests for all our vector-borne infectious diseases. And then obviously we need more targeted therapy, which based on a recent grant to Tulane, Duke, and NC State, we are trying to develop for Bartonella, is to use a more directed therapy that we actually can kill this organism and eliminate it in patients. So Bartonella henselae grew in BAPGM. We only became involved 2 months after those pictures were taken and after the initial diagnosis was made. The attending physician had started doxycycline for 2 months, and despite that, the organism was viable enough to grow in culture. The family, I think most importantly, endured, which many of these families do, substantial emotional, social, and financial price for this illness. The cost of medical interventions prior to the documentation of Bartonella henselae per the father was $4,000. The mother quit her job to provide home care for the son, and the father would sleep with one son and the mother would sleep with the other son because they were afraid that the son that had developed the psychiatric problems would actually harm himself or harm the other child in the family. So it was actually this case report that stimulated these two more recent studies from our laboratory, and I'll go through each of them. I want to acknowledge Dr. Maggi, who did all the ddPCR testing in both, Aaron Lashnitz, a PhD student in the laboratory at that point in time, and Dr. Flavio Froelich, a neurobiologist, and his colleague, Dr. Jarsko, a neurologist at UNC. And what I want to emphasize again that Dr. Alcott mentioned is that we need better direct testing methods to be able to say this organism is present in the blood, in the tissue, in the cerebrospinal fluid, in the brain, to be able to understand what is actually going on in our patients, be they animal or human. So the two innovations from our lab was initially using an enrichment culture to try to get the organism up to a level that we could sequence it, amplify it, and sequence it by conventional PCR or qPCR. The more recent advance, again, thanks to a prior grant from the Cohen Foundation, is we were able to purchase the QX1 droplet digital PCR, which Dr. Maggi will present in the last lecture of the day, which now allows us to detect Babesia, Borrelia, and Bartonella DNA with a sensitivity that exceeds what we were able to do a year or two ago. So as everyone has come to appreciate, Bartonella species are globally important emerging pathogens that were not known to infect animals or humans in North America prior to the HIV epidemic of the 1980s. Ongoing improvements in diagnostic testing modalities have allowed the discovery of Bartonella species DNA in blood, cerebrospinal fluids, skin of patients with cutaneous lesions, fatigue, myalgia, and a spectrum of neurologic symptoms, which was the basis for us starting to focus on this group of patients in our IRB study. All patients completed a medical history, a risk factor questionnaire, and provided cutaneous lesion photographs if at the onset of their neurologic disease, they either had or subsequently developed cutaneous manifestations. So literally within a 14-month period, these were unsolicited cases and obviously not a controlled study in any way. We tested 33 participants, 29 had serologic or Bartonella enrichment blood culture, qPCR or ddPCR evidence of infection. 24 reported cutaneous lesions after developing neuropsychiatric illness. And we elected to refer to these in our manuscript and we'll continue to do this for the foreseeable future as Bartonella-associated cutaneous lesions because there were a spectrum of cutaneous lesions reported. Similar to what was reported with Borrelia burgdorferi infection earlier and other infections that seem to be chronic, we've got this same constellation of symptoms occurring with sleep disorders, mental confusion, irritability and rage, and anxiety and panic attacks. And again, I would go back to that veterinary study where all these people were healthy enough to go to a meeting, but if they were PCR positive, they said in their questionnaire that they had anxiety or migraines or headaches or depression. I also want to point out that there are a number of other diagnoses listed by these patients that we entered into the study. And the interesting part is the tremors, because that seems to be fairly prevalent as I review questionnaires of some of the people that become Bartonella PCR positive. And what I want to emphasize on this that Pat mentioned in her presentation this morning is the fact that we probably need a lot more research, certainly in veterinary medicine and perhaps in human medicine, in the context of these chronic infections and various ocular abnormalities. And you'll see that these of the patients entered into the study that either were seropositive or PCR positive, ocular abnormalities were very common. Also, I think autonomic dysfunction is extremely common. Again, as John emphasized, just an area which I now emphasize to my internal medicine when they're seeing animal patients, POTS in 10 patients, and Ehlers-Danlos, if I drop down to here, in 3 patients. And I mention this in the context, again, of the previous lectures, also in the context of a case that we reported in Medicine with Dr. Robert Mosiani, in which that veterinarian that was PCR positive for both Bartonella henselae and Bartonella cholerae was actually diagnosed with Ehlers-Danlos syndrome type 3 at Harvard and subsequently at Johns Hopkins, and had near total resolution of her joint laxity with Bartonella-directed therapy. And I think, again, the only way we're ultimately going to understand cause and effect, as was pointed out earlier as well, is through treatment trials. All the other ways of looking at causation are critically important, and we should continue to pursue them. But for patients, we need direct detection, and then we need directed therapy, and we then need to know what the outcomes are going to be. So 22 out of the 28 patients were PCR positive. Of those, 4 were PCR positive by qPCR, Bartonella henselae 3, Bartonella cholerae 1, again sequenced. The problem with droplet digital PCR is it does markedly improve our sensitivity, but the way the equipment is currently designed, it does not allow for us to accumulate those targets to facilitate DNA sequencing, which is something that needs changed in some way in the future. And again, I would suggest that you listen to Dr. Maggi's lecture, which he'll illustrate this extremely well. Again, one of the problems that we documented a very long time ago is that we often need 3 samples to be able to prove that a patient has Bartonella in the blood. We know that in experimental studies that we did over 2 decades ago in cats, that they develop a relapsing bacteremia, that relapsing bacteremia is somewhat predictable in the acute stage of the infection or early after experimental infection, but then is not predictable in the later stage. It tends to lengthen the period between relapses, which obviously is problematic if we're only testing blood where the organism's in the blood, out of the blood, in the blood. And finally, what you'll see down here is that we only had 2 that were able by either qPCR or ddPCR to document blood being positive. We had 7 in which both blood and the enrichment culture was positive, but there were 13 in which either a 7, 14, or 21-day culture. On a research basis, we culture out to 21 days, and we extract DNA and test at 3 different times. Again, just to illustrate the lesions, which many of the physicians on this call are very familiar with, these Serpiginous, this is a 15-year-old male from North Carolina that was medically disabled, and Serpiginous lesions both on his hip and his buttocks. He was positive for Bartonella infection by ddPCR enrichment culture and had a 1:64 antibody titer to Bartonella henselae. This is a 21-year-old female veterinary assistant. And again, I've selected the veterinary personnel for the pictures to show you from the both included in the manuscript and from the study, because I have said this before to our physician colleagues, and I truly believe it, that the veterinary profession will become the canaries in the coal mine by which we ultimately come to better understand human Bartonellosis. And obviously, if you're seeing a veterinary worker with non-specific symptoms or neurologic symptoms, Bartonella should now be on the differential. Again, this particular person was positive by ddPCR, both from the blood and from the enrichment blood culture. and was co-infected with Bartonella henselae and Bartonella cholerae, or at least co-exposed based on antibody titers. Again, both those organisms are in cats. Both those organisms are transmitted in the laboratory by cat fleas. And cholerae we know a lot less about than we do henselae, both in veterinary medicine and human medicine. This is absolutely a fascinating case, and I would have given anything to have had a biopsy of one of these pustules, because I predict we would have been able to amplify and sequence Bartonella cholerae directly out of those lesions. But what you can see is that this veterinarian was actually scratched over a year before these lesions were taken in this picture. And he subsequently, about 6 months after the scratch, which many of us get scratched all the time, it had healed up, and then these pustules started appearing, and then he developed neuropsychiatric symptoms. And he was positive for Bartonella cholerae infection by qPCR and ddPCR, and like the young lady that I showed you earlier, only had antibodies to Bartonella cholerae with a 1:64 antibody titer. So the last publication, which regrettably the study was interrupted by the pandemic, and we had to make a decision whether to wait for COVID to go away or to move forward and report it as a pilot study. And I'm glad that we decided to do it as a pilot study, because regrettably COVID has not yet gone away. So this was Dr. Erin Lashnitz, a board certified internist who was doing her PhD in our laboratory. Erin's goal in life is to be an infectious disease epidemiologist, and I think she's attained that goal and published some really, really great work, both in animal health and human health, while she was in the laboratory, again in collaboration with Dr. Froelich and his colleagues at UNC Medical Center. So 11 of 17 patients, some of whom have been seen up to 10 or 15 years after their diagnosis of schizophrenia, were positive for Bartonella DNA in their blood. Obviously, this is much higher than the 28% that I showed you in the Lantos study of veterinarians that are at risk going to an international meeting. And in the healthy control group, doing the same group at the same time, and all testing done by Dr. Ricardo Maggi and all testing done blindly, one patient was ddPCR positive. So serology, interestingly enough, was very common among both the patients and the control volunteers. The number of scratches, the number of bites, and the exposure to vectors was not statistically different between our control population and our study population. And the other thing that may have biased this is that a large number of our control participants were graduate students and were from Asia. And I showed you that association from Asia in an earlier slide with the veterinarians. And clearly, Dr. Michael Kasoy at CDC has done some brilliant work out of Southeast Asia, demonstrating that exposure to Bartonella in that part of the world may be even more frequent than in the North American continent. So there was no significant difference in severity scores, which was another question we were asking. And important, I think the importance of this study is it provides some preliminary evidence to support future investigations to determine whether these results can be duplicated and be duplicated in multiple institutions. And most importantly, if they can, whether therapy will be of any benefit in trying Bartonella-directed therapy in improving the patient outcome. So again, I just pulled table 3 out of the manuscript, which is referenced at the end of this lecture. And you can see that if you're a graduate student at UNC, you're probably sleepy a lot of the time, you're probably fatigued, and those exams probably, if not the research that you're trying to accomplish in your laboratory. That's very different, obviously, than the symptoms that were most often reported by the 17 patients with schizophrenia. Again, similar to what we saw in the study, the neuropsychiatric illness study that I just showed you, the case series, 5 were ddPCR positive. No patient in this study was qPCR positive or PCR positive by conventional PCR. 5 were positive from blood. 7 were ddPCR positive only after enrichment culture. No patient was positive in both samples. So again, these were done at 7, 14, and 21 days, as in the previous study. So we had 3 time points. And the other thing I didn't emphasize is we had 3 samples from all the controls from some of the schizophrenia patients due to various factors, including the difficulty of getting a blood draw. We may have only had 1 sample or 2 samples from him. So there were far less samples. 1 participant was ddPCR positive at all 3 time points in culture, certainly suggesting that the organism was viable and it continued to grow in the culture. And another patient was only positive on the 2 14-day blood cultures at both time points. So we had two samples, and blood 7-day and 21-day was negative. And I include this data primarily for the microbiologists and the researchers that are also trying to improve direct detection of Bartonella. It is clearly not for the weak of heart. So
excuse me, doctor. I'm sorry, Dr. Breitschwerdt, your time is up. I'm terribly sorry.
Okay, I'm sorry. I hated your concluding thoughts. I didn't
see. Why don't you
here.
give your concluding thought? Go ahead.
All right, thanks, Pat. It seems likely that infection with Bartonella species are a more important cause of neurologic and neuropsychiatric disease than is currently appreciated. Our understanding of the neuropathogenesis is minimal and lacking in detail. Sensitivity of detection of Bartonella DNA in the blood of patients with neurologic disease often requires serial testing and ddPCR amplification. And in the context of causation or secondary opportunistic infection, treatment studies are needed to assess the medical importance of this genus in patients with neurologic disease. With that, thank you, everyone, and the references are provided.